Welcome to the webinar Urticaria under control, cause and treatment. I'm from the German Allergy and Asthma Association and I'd like to introduce you Frank Siebehaar.
Yeah, thank you, Marina. Thank you for this nice opportunity. Welcome all to the webinar Urticaria under control, causes and treatment. We are giving this webinar because tomorrow will be the second worldwide Urticaria Day, and we don't want to miss the chance to also explain to you and our patients and all interested people better what Urticaria is, what the underlying causes are, and most important, what's the basic standard and the new treatment options to treat Urticaria. Let's start and first look what actually is Urticaria. So Urticaria actually has its name from the urtica, and what you see on the skin of a Urticaria patient is the development of sudden wheal and flare reactions. Those are usually very itchy, and it's typical for those lesions that they only are on the skin for, let's say, a couple of minutes to a few hours, and then they disappear completely without having anything left on the skin. This is what we call a wheal, and this is what people having a urticaria experiencing actually several times a day, every time a week, and this sometimes for many months or even years. So you can imagine having itchy wheals every day for many, many years, that urticaria is actually really a very debilitating disease. Sometimes it's not only the wheals on the skin. Sometimes urticaria also results or leads to the development of swellings, what we call angioedema. So angioedema usually occur in your face, swollen lips, could also be a swollen eye. Sometimes you have swollen hands or swollen feet. A urticaria can actually be both, either urticaria or angioedema, or a combination of both. Here you have an example of a patient having wheals and angioedema at the same time, at the same place. Even this is possible. Urticaria actually affects both men and women. It affects also the young and the old. So we see urticaria in children as we see in the elder patients as well. Urticaria is a very, very frequent disease. So we have to distinguish, which comes on the next slide, acute urticaria and chronic urticaria. If you take both together, the entire group of urticaria, you see that about 1/3 of the general population have a risk of experiencing an episode of urticaria at least once in lifetime. So this makes urticaria one of the most frequent skin diseases ever. So if you look at the proportions, acute urticaria, which means you experience an urticarial episode that does not last longer than 6 weeks in total, then you see this is the vast majority of patients. So the vast majority of urticaria is acute urticaria, which is more than 90%, and only a minor portion, about 5% to 10%, will proceed to become a chronic urticaria, which means the symptoms last for much longer than 6 weeks. Urticaria has different subforms, and here you see that urticaria can be ugly but can also be beautiful. So on your left hand side you see a patient with a so-called urticaria factitia, or also it's called symptomatic dermographism. So whenever you rub over the skin you will induce an itchy wheal, and in this example this has even been used by an artist to make a painting on the skin. So in this case, urticaria gives a beautiful picture, but in fact it is itchy and it is not nice for the person having this on the skin. Men are not the only beings that experiencing urticaria. Also animals can experience urticaria. And here you have an example of a horse, and urticaria is even be seen in dogs. So it's not a disease that exactly affects humans. It can also affect animals. And what is interesting is actually to look into the skin and to ask and to explain what happens actually in the skin when a wheal is developing. So all of us, we have a specific cell type in our skin. This is cells that we call the mast cell. The mast cell is called the mast cell because more than 100 years ago, a guy named Paul Ehrlich, he was actually a medical student here in Berlin. He first described those cells, and he found those cells as very, very large cells sitting in the skin, and he was actually thinking that those cells were actually eating something, and therefore he used the German term Mast, which means feeding, and therefore he gave the cell the name mast cell. So all patients, all people, we all have mast cells in the skin. Usually they're sitting there helping us to defend against bacterial infections or help us help us by wound healing. Several good functions those cells are good for. In the case of urticaria, we have the problem that those cells that are actually sitting right underneath the very superficial layer of the skin get activated by different stimuli, which we come later to release inflammatory substances, mainly histamine. And those of you who ever had a skin allergy test done know what histamine in skin does, because histamine usually is used to have this one single positive control in allergy testing. So this is the one spot that gives a wheal and gives the itchy sensation in all persons. So this is how a wheal actually feels. So what happens when those mast cells in the skin get activated? They release mediators, mainly the histamine, and the histamine in the skin has various functions. It actually can stimulate sensory nerves, what you see on the right-hand side with the flash. And the histamine interacts with the nerve in giving us the itch sensation. It also works on the blood vessels, and it makes blood vessels to get bigger and to make little holes. And that's the reason why not blood, but the water component of the blood has a chance to leave the blood vessel and to get extravasated in the skin. And that's why a swelling is developing, and the dilation of the blood vessels color. So this is the cause why you have those three things you can see and feel on the skin. You have the redness, you have the swelling, which is the wheal, and you have the itch sensation, which is the urticaria symptom. Here you see that this happens. This is the edema, so water is coming out of the blood vessels, and this is mostly driven by histamine. But you see that histamine is not the only substance which is produced and released by those mast cells. A lot of other, we say mediators, so inflammatory proteins, if you so want, get also released. And that's the reason why, and we come later to this again, why antihistamines that are frequently used to treat urticaria are effective in many patients, but not effective in all patients. And the fact that other mediators besides histamine are also released and might be also involved in the developing of wheals, that could be one reasonable explanation for this. So we talked about urticaria as the most frequent form, which is chronic spontaneous urticaria, which means that the wheals appear suddenly without having a specific trigger. But there's other forms of urticaria, excuse me, we say also physical urticarias, where a specific trigger causes the wheals. This could be cold, in the sense of a cold urticaria. That could be friction on the skin in symptomatic dermographism. So then in those cases, specifically the cold or the friction leads to development of wheals. This makes those subtypes of urticaria the physical urticaria. There's also a trigger like sunlight in solar urticaria or light urticaria. So people that got exposed to the sun, to the UV light, or sometimes even the visible light, will develop in Wheals only because of the contact to light. Or some people experiencing the development of Wheals when the skin is exposed to heavy pressure. So for example, you're carrying a very heavy bag on your shoulders, and a couple of hours later you have a swelling on your shoulder. But let's come back to the chronic spontaneous urticaria, where we do not have an obvious trigger. So we ask, what is the causes? Why do people have chronic spontaneous urticaria? So when you look to underlying causes of chronic urticaria, you mainly find three big groups of underlying causes, and a third group where we actually don't know what the underlying cause is. But the three groups we know, they are divided into people, they have specific intolerance, for example, against food components or against specific medications. Some people have chronic spontaneous urticaria because they have a chronic infection, for example, in their ENT area or in the teeth or in the gastrointestinal tract. And a third group, and this is a little bit unique, we call it auto-reactive. Auto-reactive means that you have specific antibodies. Sorry, I go one back. You have, here it is, that you have specific antibodies or substances circulating in your blood. And those substances are actually able to enter the skin and to activate the mast cells in the skin to develop the wheal. Unfortunately, until today, we have some ideas, but we have not defined very clearly what those activating signals in blood is. The patients are identified by a simple test, which is the so-called autologous serum skin test. So what is done by the doctors is they take your blood, they centrifuge the blood, so to only have the blood serum left, and by using this blood serum, your own blood serum, you can do a skin allergy test. And if you don't have an urticaria and you are a healthy person, nothing will happen if you inject your serum in your skin. But if you have a chronic spontaneous urticaria, you have a chance or a risk of 30% that you react to your own blood serum. And those patients qualify for the group of auto-reactivity. For intolerance reactions, it's also specific and it's important to distinguish the intolerance from food allergy. Food allergy is special. When you have food allergy, for example, against nuts, people, they have nut allergy, they know as soon as they got in contact to a nut, they will immediately, within minutes, developing their symptoms. This also could be urticaria, because urticaria can also be a symptom of an allergic reaction. But in chronic urticaria, it's different. We are not talking about food allergies. We are talking about food intolerance. The difference is, it is other substances. It's more the food components. It could be colors, it could be artificial flavors, it could be aromatics. And the difference is also that you're not experiencing the symptoms right after you have eaten something. You're experiencing the symptoms maybe 2 or 3 days later. And this makes it particularly difficult to identify the underlying food component you're having an intolerance to. And it's particularly different because, or difficult, because to diagnose a food intolerance, skin testing or blood testing doesn't help, because we can't see food intolerance in a blood test or in skin test. Those are good to diagnose real allergy, antibody-mediated allergy, immediate type reactions, but for chronic spontaneous urticaria, it doesn't help. So in this case, people have to do specific diets, pseudo-allergen-free diets, which avoid all the possible triggers. You do this for about 3 weeks, and when your symptoms, your urticaria is getting better, then you have an idea, well, it might be a food component which is at least involved in mediating the symptoms, and then you can start looking for the specific triggers by testing the one and the other food component. So you know, and you already realize it is kind of an effort to do so, but in about 1/3 of the patients having a chronic spontaneous urticaria, this is actually the underlying cause. So it is really worth to do it. Here you see what happens when you do a pseudo-allergen-free diet, for example. The blue line, you see people doing a diet, they're not experiencing any change of their symptoms. So we measure the symptoms or the severity of urticaria by using a simple score, which we call the UAS, which is the Urticaria Activity Score. This is a very simple score. The patients monitor the number of wheals and the intensity of itch once a day, and they do it over 7 days, and then you just make a sum score, and each of those two components each day gives a number from 0 to 3. So in the end you have a maximum score per day by 6 and a maximum score per week, 7 days of 42. Here you see only the wheals, so you see 0 to 3, and you see the blue line, those are patients, they have pretty much the same intensity and number of wheals. But you see other patients that realize day by day a little improvement of their symptoms, but you also see it takes some time. So it is really important to not do a diet too short. You really have to do it at least for 3 weeks, so 21 days, better 4 weeks, 28 days, to really experience an improvement of your symptoms and to really make sure, does my urticaria respond to a pseudo-allergen-free diet? Do I have a food intolerance, or do I not having a food intolerance? So this is very important. It's not done by 1 week, it's not done by 2 weeks, it really has to be done for a couple of time. So as already mentioned, there's one group left, which is about 30% of patients, where we unfortunately do not find any underlying causes, and where we have no other chance in treating the urticaria by doing a very efficient symptomatic treatment, meaning using drugs to reduce the wheals, to reduce the itch. And the goal and the aim we have by this is really to bring urticaria under control, which means we want to treat urticaria until our patients are free of symptoms. And you see, this is possible, but it's not ever easy, but we will come to this. Before we go into the effective treatment options, I would like to not miss to mention what is not effective, because there is a lot of rumor still in information desks, in books, in articles written, what could help your urticaria. So definitely what does not help is creams. The urticaria, as you have learned, develops because you have an internal cause that activates your mast cells from the inside of your body. So you also have to treat urticaria from the inside of your body. Putting a cream on the wheals will never inhibit or reduce the activation of mast cells, and therefore does not help the development of wheals. Even cortisone creams does not help. So please don't use cortisone creams to treat your urticaria. It's not an effective treatment option. Even anti-allergic creams, which basically have the same ingredients, it's also antihistamines, but you really have to take them as an internal therapy, as a tablet. Putting those on the skin in a cream does also not help. And other things like onions or quark packs or packs of own urine or other stuff, they could help a little, let's say, because they might be cooling on your skin and thereby relieving the itch. But it's not like really picking the course of urticaria where the urticaria actually develops. We have, since a couple of years, we have international guideline. A guideline means that urticaria experts from all over the world sit together, and we last have met end of 2012, and we will again meet next year to discuss the treatment options for urticaria that have been proven to help in an international setting with international experts. And what has come out from those discussions and what is internationally recommended to treat chronic urticaria is seen in this little flowchart, and I will guide you through this. So the basic and standard therapeutic option is to use an antihistamine, and we use antihistamines of a newer generation. We say second generation. Second generation means that it's not the very old antihistamines, it's the newer ones. Why? The reason is some antihistamines make you very tired. This is the old ones. They could have side effects. They make you sleepy, they make you dizziness, they make you drowsiness. And being a urticaria patient means you have to take those drugs every day. And sometimes you even have to take them in a higher dose than usually recommended. And suffering from those side effects, sometimes if even worse than suffering from urticaria. Therefore, it is really recommended to only use the second generation, the newer antihistamines. They don't have those side effects, or at least have it to a much lesser extent. You see here an example. There have been studies taken by driving a car. And people were driving a car by taking either the new or taking an older antihistamine. And you see what happens. Actually taking a first generation old antihistamine, which is here diphenhydramine, which is the blue bar, you see you do as many or even more driving mistakes in a manner as you would have been drink alcohol. And this is an alcohol amount which corresponds to 1 promille blood alcohol concentration. So you never would drive a car by having 1 promille of alcohol in your blood. So you also shouldn't do that by taking an old antihistamine. And you see that newer antihistamines, they do actually not show a difference to a placebo, which is, well, a pill without any drug in it. So you see that the newer antihistamines are much safer and have much less side effects. So by giving this treatment to patients, or let's do something first again. The reason why you actually get tired by taking those older generations antihistamine is that the older antihistamines are more likely to cross the so-called blood-brain barrier. So usually this is a natural barrier which prevents specific substances to enter the brain. The newer antihistamines are designed in a way that they don't do it, but the older antihistamines still cross that barrier, and therefore they make those side effects. And you see that they interfere with the sleeping phases. So the normal sleeping phases, which are required that we feel awake and good the next day, are the so-called REM sleeping phases. And you see here on the left side of those pictures how a usual sleeping phase look like. You have continuous intervals of those REM sleeping phases, and on the other side you see a patient that has been monitored with the sleeping their sleeping phases by taking an antihistamine, and you see the picture is completely mixed up. The REM sleeping phases are not in a regular interval, and that's the reason why you feel drowsy and tired the next day. So treating patients with chronic urticaria with a single dose, as recommended, of a newer generation antihistamine, which we call a standard dose, helps in 45% of patients, which means 45% of patients having a chronic spontaneous urticaria taking an antihistamine will be free of symptoms. So good, it's almost half. but which is even not good, more than half are not sufficiently treated by this treatment option. Therefore, there will be a next step in the treatment recommendation due to that guideline, and it means take the same antihistamine but increase the dose. Why do we increase the dose? Well, you have to understand that a single dose of an antihistamine has actually been tested in studies to treat allergic diseases like, for example, allergic rhinitis. And allergic rhinitis is, well, basically limited to your skin or to your upper respiratory tract. Urticaria you will experience on your entire body. That means you have a much higher release of histamine, when you have urticaria compared to when you have an allergic rhinitis. Therefore, you need more antihistamine to really have enough substance against substance to block the histamine function in chronic urticaria. So it has been proven in a number of studies that increasing the dose of a routine antihistamine up to 4 times, so which means taking 4 tablets a day instead of only 1 tablet a day, is safe. It does not have significantly more side effects, and the good thing about it is actually more effective, which you see here. If you give an increased dose of an antihistamine, 65% of the patients will be symptom-free, which is much better than only taking 1 tablet a day. The bad side still is we still have about 1/3 of patients that are even not sufficiently treated by a quadruple dose of a standard antihistamine. So here we have a group of patients where we definitely have a need for other treatment options. But let's stay with the antihistamines for one more second. You could come to the idea, well, when I take 1 antihistamine, even in a higher dose, and it doesn't help me, why do I not take another antihistamine in addition, or maybe a 3rd one in addition? Here's a study, it's a couple of years old, which shows you that this is not effective. So you see, maybe I show you this with the pointer. Here you see the combination of 2 antihistamines, which are both taken twice a day, and you see the effectiveness is low. Here you see 3 different antihistamines, also taken, each in the morning and in the evening, and you still have not the same efficacy than staying with 1 antihistamine, which you take 2 times a day, saying 4 tablets a day. So this is the most effective treatment options by treating chronic urticaria histamines, but we cannot go higher than 4 times the standard dose, because then we come into an area where we have not really good safety data. And as mentioned before, chronic urticaria has to be treated for a long time. So the patient has to take this treatment for months or even years. And with a quadruple dose of antihistamine, this is possible, but with a higher dose, we don't know, because there's no clinical trials, there's no studies, we don't have good data, so we don't want to put you on the risk of experiencing long-term side effects in taking too much antihistamine, but 4 times a day is okay. So what will be the next step? The next step will be that we, sorry, now I have a little problem with the presentation. Here we go. Sorry, this was the wrong direction. Here we go. So the third step is actually that we use additional treatment options. And here we come to a number of different drugs which are not routinely used in chronic urticaria, but which are used in very severely affected. And one of the, let's say, most effective treatment or drugs is Omalizumab. Omalizumab has been introduced into the urticaria world, let's say, a couple of years ago. It is a so-called anti-IgE, so it blocks allergy antibodies, which are also involved in type 1 immediate type allergies. And the drug has initially designed to treat allergic asthma. But since a couple of years, we also know that it really helps a lot in chronic urticaria patients which are not symptom-free due to other treatment options. And let me tell you a little bit more about it. So the Omalizumab is not a tablet. It is an injection, actually, which you have to receive, but you only receive it once a month, not every day, once a month. So the drug lasts for 4 weeks, and the efficacy of the drug has been studied in many clinical trials over the last years, which actually have led to licensing of this drug to treat urticaria early in 2014. I'm telling you this because it has been really a milestone in the treatment of chronic urticaria. So here in our department, we're taking care of urticaria patients for more than 15 years. And we had a lot of patients which we treated with high-dose antihistamines, with a combination of not only as antihistamine, also using other drugs, and those patients were not getting free of symptoms. And the Omalizumab is so effective that patients having not been symptom-free for years are symptom-free of this drug. So it's really a magic bullet, so to say, in the world of urticaria, and it's of great benefit for really highly affected urticaria patients. So here you see an example of one of those studies. So you see this is all patients that have been treated for years and not being symptom-free. And the red line, you see the patients that were in the placebo group in those studies, so receiving an injection but without the drug. And you see they improve a little bit of their symptoms, but then very immediately they stay on a high level of their symptoms. Whereas the group received the real drug, they had a tremendous drop of their symptoms, and they stayed almost symptom-free as long as they received the drug. And when you stop the drug, well, then the urticaria comes back. So this is also important. This injection is not taking urticaria away. It also only blocks the symptoms, but it does it in a very effective way. Here you see one example from our clinical experience, because one side it's the clinical trial, it's a specific setting, but if you really look in real life by treating the patients, you see that most of the chronic spontaneous urticaria patients, meaning more than 80%, will be off symptoms with this treatment. And it not only helps in chronic spontaneous urticaria, it also helps in other forms of chronic urticaria. The physical form, inducible forms, as we say, so the forms that are developing due to cold or UV light or pressure, for those kind of urticarias, unfortunately, the drug has not been licensed yet. So it cannot be used in the clinical routine. Maybe it will be in future. Only to show you that this could be in future also a treatment option for patients not having spontaneous urticaria but having or suffering of one of the inducible forms. I also want to show you that, of course, not all patients get rid of symptoms by using those newer and alternative treatment strategies. I picked that slide because we're talking about urticaria under control in association to the World Urticaria Day tomorrow. And therefore, we also have, of course, to talk about the patients that are still not being treated well by the currently available treatment options. This is the most important patients, actually, because there still is the need. This is why we work on research in urticaria still every day. So we're not on the end. We are still developing more and better and more effective treatment options. But here you see that even with the drugs that are available, we play. So there is some people that get free of symptoms by using those drugs, but I told you, you get the injection every 4th week. In some patients, the symptoms come back earlier. The omalizumab doesn't last for 4 weeks. So then, of course, we have the possibility to shrink the treatment intervals. So give the next injection not after 4 weeks, give it after 2 weeks already. Or there's other patients that realize a significant improvement of their symptoms, but they are not completely getting symptom-free. And in those patients, it is worth to even increase the dose of omalizumab. So the standard dose of this drug is 300 milligrams, which is actually already 2 injections once a month. But you could also give 3, or you can also give 4. This is safe to do so because, as you heard, the drug usually was used, or is still used, but initially was used to treat asthma patients. And asthma patients usually receive a much higher dose than urticaria patients do. So we have pretty good experience about the safety profile of this drug. We know that patients tolerate higher doses than 300 milligrams over years. So it's okay to also increase the dose in urticaria. Problem is a little bit on our side that it is licensed for a specific dose of 300 milligram in urticaria. So it is in some countries a little bit of a difficulty to increase the dose because it might not automatically covered by your health insurance. In some countries it's not a big deal, in other countries it is a deal. So in Germany, for example, we have to ask the health insurance, we have to apply for admission. Sometimes it works if you have good reasons. So you have to discuss with your doctor if you are a patient that are treated with omalizumab, but you are not really symptom-free, if this could be an option. Please go back to your doctor, discuss the opportunities, what could be done. To give you some examples of the physical urticarias, just here I want to introduce that we have also developed specific devices to actually test treatment efficacy. For example, the Frick test, which is a simple device used in symptomatic dermographism. So you see here those stripes on the skin. That is how a patient with symptomatic dermographism usually reacts to that test. So you see there is wheals developing, excuse me, and those wheals will also itch. When you, here another example, and you also see you have 4 pins on that device, and you see on the most left side you have clearly developing wheals, you have the erythema around, and on the right side you only actually see an erythema, you don't see a wheal. So you see there's different kind of forces you apply by this device, so you could also measure how good it is, because you will only get 1 wheal or 2 wheals, but not 4 wheals. And here's an example. One of the first patients we treated with the anti-IgE, and you see even in the symptomatic dermographism, this is very effective. On the left side you have wheals, on the right side you only have the erythema. You have to believe me, the patient also mentioned it's not itchy, and this is the most disabling symptom, of course, in symptomatic dermographism. Another example is cold urticaria, where we also have developed the Temp Test. Some of you have heard about this before. This is actually let's say an electric ice cube. So there's little Peltier elements that could be cooled down to specific temperatures, and by using this device you could in one attempt, applying this to the forearm, define not only that you respond to a wheal. If you use an ice cube, for example, you will apply 4 degrees. All urticaria, cold urticaria patients will develop a wheal on 4 degrees. But there is differences from patient to patient in the temperature when the wheal development actually starts. And you see with this device we can apply simultaneously different temperatures, actually all temperatures between 4 and 24 degrees. And you see in this example, patient is still developing a wheal at 20 degrees Celsius, but not at 22. So we have the threshold temperature, and this is also going to change under treatment. So the temperature will not stay with 20, it will come down, and maybe it's then only 8 degrees, which means between 8 and 20 you will not develop wheals anymore, but before you would also have developed a wheal by 20 degrees. So this is a good marker to measure treatment efficacy, and it's mainly used to monitor objectively, not only in clinical trials, but also to make a good documentation, which is oftentimes needed for health insurances, and which is also good for the physician-patient interaction, because you also can see that your symptoms have improved and to what extent your symptoms have improved. Another example by an efficient treatment, and this is a patient with solar urticaria. She was very severely affected, and you also see that the injection, actually the first injection of the anti-IgE, she get completely rid of symptoms. This is a good and positive news, with which I would like to finish this presentation. I would like to give you a short summary so you know that urticaria is a very frequent disease. Acute is more frequent than chronic. Those of you suffering from urticaria, you know that this is an incredibly annoying and sometimes even disfiguring disease if you also suffer from angioedema in your face. The chronic spontaneous form is most common. The inducible physical forms are more infrequent. You have learned that possible underlying causes of spontaneous urticaria could be chronic infections, food intolerance, or autoimmune, auto-reactive processes. This is the most three frequent groups of underlying causes. Chronic infections, food intolerance, good to know about them, because sometimes you could change something and urticaria could disappear. With the autoimmune, auto-reactivity, we're still seeking for the underlying cause, or to try to identify the triggers in the blood of patients. Maybe this will also lead into new treatment options in the future. And the possible therapies for today is antihistamines first. Second option, more antihistamines, up to 4 times the daily recommended dose. And third line is inhibiting the function of mast cells, by example using one of the newer drugs, for example the IgE, which has started over the last years and is a good benefit for some patients. But there is still clinical trials going on. There is still more modern and innovative treatment options under clinical investigation. So if your urticaria is not under control and you're looking for better treatment options, please ask to your doctors. Try to find the next urticaria center which is closest to you. Get in contact to them. Most of the big clinical studies are actually conducted in many centers. Most of the studies are worldwide, international studies. So you're having a good chance that you also may be able to participate in a clinical trial close by to the area where you live, and to benefit from new and even more effective treatment options as those we have available for today. So I also wanted to remind you that Urticaria Day is tomorrow. The motto is your urticaria under control? If you want to know if your urticaria is under control, except for the symptoms you feel, you can actually find out by using a very simple test. And please also introduce your doctors to those tests, because it's a very easy tool. We call it the UCT, which is the Urticaria Control Test. And it's a very simple test. It's a 4-question test with 4 simple answers. And if you answer those questions, you immediately know, do I have a need for a better treatment option, or do I have my urticaria under good control? You can find this test on the website of the Urticaria Day, urticariaday.org. Please go and visit and do the urticaria control test if you want to. So this session, first of all, thank you for your attention. And what I have forgot to mention in the beginning, we have now 15 minutes left. You have a chatting option in your GoToMeeting program. So please feel free to type in your questions in the chat box. I will read them immediately now and will be answering those questions by oral. So we have now the chance until 6 o'clock to discuss your questions and your individual concerns, your comments, your experience on urticaria, on your treatment. So please go ahead and ask your questions now. Thank you for your attention. Celebrate with us the Urticaria Day tomorrow. Look around. There will be probably also other events going on in your area. Use the webpage which informs you about the events going on. There's also the chatting option to get in contact with other patients all over the world. So please use this tool and make the Urticaria a good event, and let's put our efforts together to bring all urticaria patients under control. Thank you for your attention. Goodbye.